right, well, hello everyone, and welcome back to the second edition of the CSCS Beat, More Than Just Matters of the Heart. My name is Ansar, Hassan. I'm a cardiac surgeon here at the New Brunswick Heart Center in St. John, New Brunswick, and I'm also president-elect of the CSCS.
And my name is Rakesh, Arora, cardiac surgeon intensivist from the University of Manitoba in Winnipeg, and the current president of the Canadian Society of Cardiac Surgeons.
You know, last month we launched our first ever podcast. It was entitled "Does TAVR Mean the Death of SAVR?" with our guest speaker, Dr. Jean-François Légaré. And first of all, I thought it was great. And a special thanks to our sponsors, Edward Life Sciences, for providing the support for this podcast series, and also to our production partners, Bangal Albino, who've really kind of come forth and provided us with incredible technical expertise. Hey, Rakesh, did you have a chance to listen to that podcast yet?
You know, I did. And for a first attempt, I think we did pretty well. For those who haven't listened to it yet, you can find the podcast and eventually all other podcasts on iTunes and Spotify, as well as the CSCS YouTube channel. And so do you have any idea how many people actually listened to the podcast so far?
Well, I know as of yesterday, the YouTube version had 25 views. Now, I must admit, I don't know how many people have listened to it on iTunes, but I do know that my mommy and daddy listened to it and they loved it. You know, they said, "You and Rakesh sound just like Dr. Sanjay Gupta. And why is TAVR trying to kill SAVR?"
Okay, well, I know at least one thing. We fulfilled one key objective. That's bringing us together, cardiac surgeons from across Canada, to discuss matters in a casual, informal, and safe, some of these the hottest and controversial topics facing our specialty.
You know, and I think tonight will be no exception. The topic for tonight's podcast is evolution in the management of acute heart failure, a shocking development. And we have two esteemed colleagues from across Canada joining us tonight. We have Dr. Mitesh Badawalia, who is an assistant professor of surgery at the University of Toronto, and he's a staff cardiovascular surgeon at the Peter Munk Cardiac Center at the University Health Network in Toronto. And he's also surgical director of the heart transplant program at UHN.
Yeah, and we've got Mark Laskowski, the director of the CICU and the shock team at the Montreal Heart Institute. Thanks both for you joining us tonight, and we welcome you to this podcast.
Yeah. Look, cardiogenic shock, as you know, Rakesh, is associated with considerable morbidity and mortality. The management of patients presenting with acute heart failure and cardiogenic shock has seen tremendous evolution over the past few years. And I think the creation of multidisciplinary shock teams have been undertaken in many institutions, like as a way to try to improve outcomes in these patients.
Yeah, I think to that point, we're going to welcome back Dr. Jean-François Légaré, the head of cardiac surgery at the New Brunswick Heart Center, and the past president of CSCS, to provide a brief overview and frame for this discussion we'll have with our two guest colleagues this week on the management of acute cardiogenic shock. JF?
Thank you, guys. So acute cardiogenic shock in everyday practice remains a very challenging condition to recognize and to treat. And I think there are several problems to that. The first problem being that not much has changed since the original shock trial, as shown here, comparing revascularization to medical therapy and basically showing that early cardiac catheterization and revascularization provide a survival advantage. However, despite this, almost 20 years ago, mortality remains high and probably as high as 50%. The second problem that we're facing is that physicians are often approach this in very different ways and perspectives. And furthermore, often these approaches are often poorly aligned with each other in many ways. Whether you're a clinical cardiologist, an interventional cardiologist, an anesthesiologist, electrophysiologist, or a cardiac surgeon. And this has also occurred in the context where there's been tremendous increase in the use of extracorporeal membrane oxygenation, or ECMO, across the world, and particularly in North America, in trying to deal with this problem and in trying to deal with patients with cardiogenic shock. And that has led, obviously, with tremendous pressure in many of our healthcare systems in trying to deal with this. So unfortunately, this is also in the context of having limited trial evidence to guide us and to guide clinicians. There's been no clear benefit in many of the trials looking at mechanical circulatory support. Even if there's limited evidence, these have looked at balloon pump and an Impella, for example. However, there appears to be some evidence suggesting that a multidisciplinary approach and a concept of a shock team potentially has some benefit and can actually improve outcomes. And this is where this has led to some authors proposing that the contemporary management of cardiogenic shock should include a shock team. And but what does a shock team mean? What is it composed of? How do we roll that out? And hopefully, this is where in today's podcast, our experts will tackle this complex area with their unique perspective and help us. Thank you.
Thanks, Jeff. That was a really great overview and a good framework to start this conversation. And there's a lot of perspectives that you've highlighted are part of this in the treatment of cardiogenic shock. And this has evolved dramatically over the last several years. Let's bring them back in, Mark and Mitesh, to get some of their opinions on this. Let me start with a basic question, Mark, maybe for you to start. How do we improve the diagnosis of cardiogenic shock? That really seems to be the primary foot in the door to activate a process to get that patient the right help as quickly as possible.
Yeah, so I think the biggest problem is that, all shock tends to sort of resemble each other at the beginning. So the emergency room on the ward, everybody looks kind of gray and clammy, and people with a Foley catheter, and they're all sort of oliguric, hypotensive. So it's really tough just clinically to get an idea of what it is. Could be septic, obstructive, as much as cardiogenic if you don't have an index event like an acute MI. So I think what's important is sort of what Navin Kapoor has been talking about these past few years is try to identify the phenotype of the shock you have. I think by trying to identify what kind of hemodynamics your patient has allows you to decide what's the best place for this patient to be, or what's the best therapy the patient needs. And that might mean transfer to a coordinator center or a center that has advanced mechanical support or a shock team. So in using that principle of what's your phenotype, I think the most important thing is to use invasive hemodynamics. And I think that's the initial thing that we have to do these days, is to probably get a good idea of what the initial numbers are in terms of filling pressures and a certain calculations that we know how to use now, the PAPI and the CPO, to get a good idea if the patient's a survivor or non-survivor, and from there go on to advanced therapies.
So Mitesh, I mean, kind of building on what Mark has just said, from your standpoint, should there be a basic level of invasive monitoring in these patients, and what should that basic level be, and how do we enforce it? Because I think that's an issue that we're all facing when we're presented with these patients is, the one thing we complain a lot about as surgeons sometimes is just that we don't have enough data. So what are your thoughts on that?
Yeah, I agree. I mean, we receive a lot of outside calls for shock, being the heart failure center in Toronto. And so when we take these calls, we ask for that data. And part of it is asking for the right heart cath data. And if they're not able to provide it and they have a patient who fits the clinical diagnosis of shock, that's when we go through our critical system to bring them to our institution. And then the pathway splits into two. If it's a ischemic etiology, they go to the cath lab and they get a right heart cath there. But if it's not an ischemic etiology, then we bring them to our critical care unit, either the med-surg ICU or more typically the CICU, and do a right heart cath to identify that phenotype. So at some point, a part of our shock algorithm involves right heart catheterization. And so if an outside institution has a patient that they're worried about and they call us through our critical system and they're not able to provide that data, then that's one of the triggers, if the patient doesn't have other exclusionary criteria, to bring the patient quickly to our center for that identification.
Right, so really good points there. So you've got a patient now, you've identified a potential risk of this patient having a phenotype that's consistent with a cardiogenic shock. You bring him to your center for right heart cath. What do you do next then? What's the process to activate the team, Mark? What have you learned in your shock team at the Montreal Heart Institute?
Also, the biggest problem we had is that there was many ways to contact cardiologists, surgeons, or critical care physicians in our hospital, and the poor operator didn't know who to call when somebody was calling for help from another center.
Right.
So we decided to right away route all the calls to the main heart failure cardiologist on our cardiac ICU, and he would sort of field the initial physiological and data on what kind of patient this is, and decide to pull the trigger. And we decided that he would be the one to call and contact all the other members of the shock team. Either if it's a couple of his colleagues, he can contact right on the phone, or ask the operator to ring in all the other team members, the surgeon, the intensivist, the interventional cardiology team, just so we have a proper idea of who's on the phone, and discuss the case real time, even before the patient gets transferred over, in case somebody brings up points where this patient's not deemed to be transferred. But I think most centers, I'd say, would have a big problem is, how do you initiate this shock team call? And right. I think we've gone through many versions, and I'm not sure if we have the best one, but we're willing to modify that as we go along.
Right. So I know, Ansar, maybe I could just ask one more question. I may have jumped the gun a bit of a process of communication. Let's take one step back. Who should be on this team, Mitesh, and how do you get those people to work together? Once you activate this process, you need to know who needs to be activated. Who should be on that team?
We've gone through a similar process of it being haphazard, where it used to be the cardiac surgeon, and then they'd call the heart failure cardiologist, or it'd be the heart failure cardiologist calling the surgeon. And we basically, through experience, have whittled it down to the point person being the heart failure cardiologist on call. They call the cardiac surgeon on call for heart failure and transplant. The two of them initially discuss the case. And if the patient fits eligibility for activation of the shock algorithm, then we involve our medical surgical ICU intensivist, because that's where the patients ultimately will go if they have ECMO, for instance. We don't involve the interventional cardiologists unless there is something for them to do, essentially. We've learned that having too many cooks kind of makes things confusing. And so we've whittled it down to initial two-person conversation. And if there's a lack of consensus between those two who happen to be on call, our group is very collegial, and we wake each other up and either circulate an email very quickly and have a consensus opinion built pretty quickly in cases where there is some doubt or lack of agreement. So in terms of the team, it's a surgeon, a heart failure cardiologist, plus or minus the med-surg intensivist, plus or minus the interventionalist if required.
Yeah, and it's interesting to hear you say that, because I think, let's be honest, each center, you're going to have to personalize the team to what your strengths are, right? I mean, there's probably not one formula that fits everyone. But I guess, let's back it up even one step further. Is it safe to say that every major cardiac center in Canada should have a multidisciplinary cardiogenic shock team? Mark?
Well, I think so. I mean, the models that are coming out of the US clearly show the advantage of having sort of a hub and spoke model, where clearly within certain geographical distances, you have at least one big center that has all these team members that can do cardiac surgery, advanced support, heart failure. Maybe not necessarily transplant, it may not be available in all places, but at least the main team that can get people onto maximal support like ECMO, or make decisions, simply not to. So I think that, given the size of Canada and the outlying regions, I think every major city should have an advanced multidisciplinary team that has a cardiac surgery unit on call.
Right. So Jeff, you got someone now, you had your heart tube discussion, you go, okay, this patient needs support. They're not going to make it, which is inotropic support or perhaps just a balloon pump. Should we be thinking ECMO, Impella? What should be that decision tree?
I think, as these guys suggested, the hemodynamic monitoring is super important. My questions were more, not the type of device you're going to use, but the approach you're going to have. Once you've got the information, you got to right away, time is important on your initial maneuvers. If you think it's hypovolemia, give some volume, see response. So the question to these guys is really, when has too much time evolved to then trigger the next step and the next step? You need processes in place where, you're going to try the first inotrope, you think it's going to work, it's not going to work. 15 minutes later, your next gas, you show, worsening acidosis, what am I doing? And this is where the engagement is so important, and how you're approaching this. Time is key. Time with poor perfusion is key. Lactic acidosis and worsening end organ perfusion is really going to kill you in the end. And you got to do everything to prevent that. And as soon as you start having those things, you've got to obviously, intervene. And the intervention where we are, we don't have numerous devices to use. So for us, the approach would likely go to ECMO for what we do, because we can provide biventricular support, unless there's obviously different things you'll learn from the information you've obtained.
One of the things I noticed in one of your talking points, JF, was that, it's interesting that ECMO utilization has clearly gone up. And Mitesh, maybe I'll ask you about this, but then survival hasn't really changed necessarily over time. So maybe, building on a little bit of what JF just said about, really having processes in place and, knowing, when to kind of move to the next step so that, there isn't a big delay and there isn't a big lag. What are your thoughts in general? Because obviously ECMO and Impella, they're comparable systems, but they're also different. What's your thought about, the general feeling that now a shock team equals going straight to some of these devices?
Yeah, so we've learned through experience over a relatively short period of time, over the last 6 to 10 years, that if you are aggressive and put everyone on support, your outcomes are going to be poor. Garbage in, garbage out, unfortunately. Mm-hmm. And so we've become very, very particular about assessing the patient upfront very quickly to determine whether they have an exit strategy. For instance, if they are supported with ECMO, what's the next step if their heart doesn't recover? Are they eligible for that next step? And then excluding those patients that we've tried to support with ECMO, but it just doesn't work. Patients above the age of 75, if they have an ischemic etiology, even above 60 to 65, we've had terrible results. And so we are very, very discerning about patients in that age group. Patients who've had unwitnessed cardiac arrest more than 30 minutes outside of hospital, we've had very, very poor results. And so we are less aggressive about treating those patients because unfortunately, we feel that they're too far gone. And so there is a point of no return. And I think through experience and data and reflection on your own data, you'll see that those are the groups that if you exclude and you focus it on the younger patients who may have myocarditis or reversible causes or exit strategies, you can bridge them and have their end organs recover and then move them on to transplant or VAD or other therapies, as opposed to them dying of an ECMO complication with no out.
Yeah, so just to build on that there, then maybe Mark as well. I think what I'm hearing from you, Mitesh, is before you start a therapy, make sure you have a way to get off from that therapy as a first screening tool. Mark, what's been your approach at the Montreal Heart Institute?
Very similar. I think with Johan Lamarche in our center, we've developed a very short list of inclusion criteria, but pretty long list of exclusion criteria. And it's really important to sort of really not jump the gun and end up on ECMO, and then you're stuck, right? You're stuck with a patient who might neurologically survive, wake up, and then you're stuck with a patient who has no exit strategy. Right. So it's really important that your center has, based on the strengths that it can offer your patients, a very good list of exclusion criteria and really stick to them. That's really very, very important. And everybody's, a nice guy, and he was a really good person, and he's kind of young, or he looks young, but, really, I think the age criteria, the duration of shock, lactate cutoffs, I think those are all really important numbers to stick to, because as Mitesh mentioned there, as soon as you're outside of criteria, your mortality rate goes way up. And that affects your statistics. And obviously, probably there's no way out for those patients anyways. Cardiogenic shock has a horrible mortality. So you really have to focus all your efforts on those that can survive, because again, it's a very high resource utilizing endeavor.
Right. Well, that brings me kind of, as we wind this down, and it's been a great discussion up until this point. Thanks so much for joining us, Mark and Mitesh and JF. As you said, shock teams are resource intensive, right? I mean, they're costly. And I mean, if we think about it from a budget standpoint, whether it be the devices that we're using, whether it be the time that's spent, the invasive monitoring that's applied, the ICU and, resources that are, utilized, it's not cheap. So, let's put our administrator hat on for a second. How do we measure success? What's a metric? And I would kind of ask all three of you to weigh on this, because I think, people measure success differently in different institutions. I'm sure it's measured differently in Canada versus the US, but let's start with Mitesh and JF and then back to Mark.
Yeah. So, our administrators are always, concerned about this topic, because in Ontario, as you may or may not know, it's unfunded. Putting someone on VA ECMO for these indications is actually an unfunded activity and costs the hospital money. And so, we have outlying hospitals that have cardiac surgical units that have no interest in putting these patients on ECMO. But because we're the local transplant VAD center, advanced heart failure center, we feel obligated to. So our measure of success may not be, fiscally motivated. It actually is entirely motivated on getting patients through to survive. And so we measure our survival off of ECMO, but also what we are now tracking to see if we're improving the overall shock algorithm is tracking the patients that are referred to us through critical, the percentage of them that we actually accept. And what the characteristics are, to see if they're being referred earlier as opposed to being later and not salvageable, to see whether or not our message is moving out into the community of calling us early, discussing cases with us early, so that we can actually provide meaningful survival options to these patients who would otherwise die.
So try to ensure that people are pulling the trigger sooner rather than later.
Correct.
Yeah, great.
JF?
Yeah, I see it as a way to educate our nursing and our clinicians that we actually can intervene much earlier in the shock process. in which you may actually use less of these very expensive technology. And if anything, if I've learned one thing, is it's really helped as a team in general work more collaboratively. And it's really helped us sort of deal with these difficult situations and have the conversations about the exit strategy and all those kinds of things upfront. So maybe there is an angle here where you can actually have some cost savings and think of cost savings by actually dealing with more appropriate and earlier, simpler interventions in these patients. Anyways, that's my take on it.
And Mark?
So last 3 points, I think first off, the invasive hemodynamics might guide us pretty well. I think that from the data coming from the US, based on certain CPO or PAPI scores, I mean, if your hemodynamics are adequate and you're in the survival group, you probably don't need, the heavy artillery and major mechanical support, and you might be able to survive on, 1 or 2 inotropes at most with revascularization or otherwise. Once you do have the numbers that show you need support, I think you're going to die if you don't get that. And from there, you have to move to clearly making sure the referral centers are aware of how to contact you as early as possible, because we have a bunch of patients that we got very early within a few hours of the initial event, and they walked out of the hospital a week later, 2 weeks later. We have patients that were delayed and they spend 3 to 4 months in hospital, and I'm not sure what their 1 year recovery is like functionally.
Yeah.
So I think it's really important to communicate, to have feedback and rounds with your referring centers to make sure that, hey, this is your patient, you sent this early, this is the survivor that's walking home. And that's, I think, the most important loop in the whole project. And last thing is, as your exit strategy, don't be afraid to just consider palliative care as an option. So I think at a certain point in time, you can't let the patient run an ECMO for 1, 2, 3, 4 weeks just because the attending is changing every Monday morning. I think if you were able to plan day one, fine, we'll give it 3 to 5 days based on etiology or an exit plan, which could be transplant or not. You got to stick to that, because once you're past 5 to 7 days, then you start to get all the other complications that prolong the care of the patient.
100%.
Good points.
If I were to say one more comment on the, what's the biggest impediment to us being successful in this area, I still think it's our ability to recognize shock state, despite us talking about, the patients where it becomes obvious, and then we're doing hemodynamics, we're doing all these things. The problem is there's probably lots of delay in reaching when it becomes obvious, we're probably behind the 8 ball.
Absolutely. I think that's a great way to end this talk and this session. And, I thank you everyone for taking the time out of your busy schedules to join us. I think this was valuable, and I'm sure our listeners will really enjoy the back and forth, and it was fun, which is kind of exciting all at the same time. And I'm sure my mom and dad can't wait to hear this one too.
Right. Well, on that note, once again, I'd like to thank our sponsors, Edward Life Sciences and the production team at Bang on Vinyl, for putting this all together. This wraps up again tonight for the CSCS Beats, more than just matters of heart. Stay tuned for more podcasts in the near future. Thanks, everyone. These recommendations reflect emerging and clinical scientific advances as the date have issued and are subject to change. These statements are intended to assist practitioners in the clinical decision-making, and each cardiovascular specialist must still exercise his or her own professional judgment in determining the proper course of action for each patient's differing circumstances. The CSCS assumes no responsibility or liability arising from any error or admission in the use or from the use of any information contained herein.